I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the MedEd 101 Nursing Pharmacology Review course at meded101.com/nurse. MedEd 101's Nursing Pharmacology Review course is built to make meds finally click. You'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed by pharmacology experts for nurses. Stop memorizing, start understanding pharmacology at meded101.com/nurse. In this section, I'm going to cover some basics on pharmacokinetics as they pertain to medication use. All right, ADME. This is a very important acronym to remember. Absorption, distribution, metabolism, and elimination. These are all important processes that essentially what the body does to medication. So absorption is that initial taking in of the medication, getting it to the bloodstream. Distribution is where that bloodstream takes it. Does it get to the brain? Does it get to the site of action? Or wherever that may be. Metabolism is how medications are broken down. This is primarily by the liver. And of course, elimination is generally described as getting rid of that drug out through the urine, or excretion is another name for that. Half-life is going to be an important term to remember. This is basically how long the drug lasts. More definitionally, it's the amount of time that it takes the body to eliminate half the drug in the body. Okay, so let's say you got 50 milligrams per liter. That's the current concentration. How long does it take for the body to eliminate, to metabolize that medication to get to 25? That would be considered the half-life. For many drugs, it's, a shorter half-life is probably in the neighborhood of, 2 to 4 to 6 hours. Longer half-lives, can be days potentially, maybe even weeks and months in some rare cases. So this can definitely vary. And probably the biggest thing that half-life is going to affect is the dosing. Okay, so if you see a drug, so let's take amoxicillin, that's generally got to be dosed a few times, 2 or 3 times per day. And the reason for that is the half-life isn't crazy long, right? It doesn't have a half-life of 24 or 48 hours. It's got a half-life more along the lines of, 2 to 8 hours. And, and this can vary depending upon kidney function and those type of things. But, the shorter that half-life, the more that we have to dose that medication. There are lots of different factors. The formulation, the specific drug itself can affect half-life. How well the kidney is working, how well the liver is working, and the metabolism elimination process. That's probably the greatest specific variation that you're going to see. In geriatric patients, generally their kidney function has declined, so in older patients, so they might not get rid of that medication as quickly as, when they were 40 years old, for example. So that's an important thing to think about with regards to half-life and the ability for the drug to hang in the body a lot longer when our processes that break drugs down aren't working as well, or getting rid of drugs in the body. All right, a little bit more about each individual term here. So elimination. Creatinine is actually a waste product. So when we're talking elimination, we can measure how well we are eliminating or how well the kidney is working. So creatinine is a waste product generated from normal muscle metabolism or breakdown, and it's released from the muscles at a relatively constant rate. And this substance, creatinine, is primarily filtered by the kidneys and excreted in the urine. So what that means, we can judge kidney function based upon creatinine. If a kind of a steady amount is released from the body under most normal circumstances, if that creatinine in the bloodstream is rising, we know that that kidney function isn't working as well. We're not pumping that out of the body. And so that's why you see creatinine levels checked quite a bit, and it's definitely an important thing to monitor as far as drug elimination and those type of things go. And here's just kind of the mathematical formula if this interests you. So we can calculate what's called creatinine clearance. This is a function of how well the kidney is working. And with creatinine clearance, the higher the number, the better the kidney is working, or generally that's what's considered. And, over time, as patients age, or maybe they have chronic kidney disease, you'll see that creatinine clearance go down. So you can see what's in the formula. So age, it does factor that in. And then, of course, serum creatinine is the major determining factor of whether that goes up or down as far as creatinine clearance. All right, let's move on to metabolism. So drug metabolism is the biochemical breakdown or modification of medications by the body, and this helps with the elimination process. From a physiological standpoint, really what the liver is meant to do is destroy toxins. So, and break down things that could be harmful to the body. And obviously a drug or a medication, that's seen by the body as foreign, something that we want to eliminate and get rid of. And so the liver has these mechanisms to try to alter medications and toxins to eventually get rid of them. Again, most of the metabolism occurs in the liver, definitely a super, super important thing to remember there. And it's what's called the cytochrome P450 system within the liver. And there are various subtypes of these enzymes, and different drugs can be affected by different subtypes. And as we get into specific medications, I might touch on that briefly, but I think that CYP P450 system is a good thing to remember. There's also phase 1 reactions with like oxidation and reduction and hydrolysis. I'm not going to go into the specific details of that, but there are other mechanisms of breakdown just besides that cytochrome P450 system. Phase 2 reactions involve conjugation, where that drug is linked to a larger water-soluble molecule that can ultimately be excreted in the urine. Metabolism typically transforms more of those lipid-soluble drugs into more water-soluble compounds. And when we get those water-soluble compounds, they can be better excreted by the kidneys. All right, so a little bit more specifics. We can have some genetic variations in CYP or P450 enzymes, and this can alter metabolism rates. So let's take a specific example. If we've got a CYP2D6 inhibitor, or a CYP2D6 slow metabolizer, so drugs that are broken down by that particular CYP subtype, drugs that are broken down by CYP2D6, if that enzyme isn't working as well as we'd like, those drugs are more and more likely to accumulate in the body, and you're more and more likely to see adverse effects. So that's kind of a quick example there. We can also have drugs that induce and inhibit. So if we induce the action of CYP2D6, we're causing it to be more active, and it might break that drug down quicker. If we've got drugs that inhibit or block the action of CYP2D6, medication like paroxetine might accumulate, and you might be at more risk for adverse effect. Liver disease can significantly reduce the function, the metabolic capacity, so we may require some dose adjustments there. Again, oftentimes it depends upon the specific medication. Age, In general, as we get older and into geriatrics, talking about 65, 75 plus, that action of metabolism, and I guess I'd throw in excretion as well, tends to decline. First pass metabolism, this occurs when oral drugs are extensively metabolized in the liver before reaching systemic circulation. So this ultimately reduces bioavailability, which is basically the amount of drug that's available to have pharmacological actions. Metabolic pathways can also produce prodrugs or alter prodrugs. So basically a prodrug is a medication that is typically given orally, and the body actually converts it to a compound that is more active or has more activity that we're looking to do there. And then obviously most metabolic pathways, can change things into inactive substances. I mean, that's primarily the goal of the liver would be to inactivate any type of toxin and that type of thing. However, sometimes we can alter that with our various metabolic pathways, and it may turn it into a more toxic substance as well. Not terribly common that happens, but there are case examples of that. Volume and distribution. This is essentially the theoretical volume of fluid that would be necessary to keep the drug at the same concentration in the plasma. Equation-wise, it's represented as VD. Not going to spend a ton of time on this. I think this probably goes above the level of what we need. But I do want to mention that volume of distribution can be important as far as eliminating the medication and getting it out of the body. So if a medication has a high volume of distribution, that means it's distributed into large areas of the body versus a smaller volume of distribution. That means it's in smaller areas of the body, that type of thing, and would be less likely to kind of linger and hang around. Hey, nurses and nursing students, want to reinforce pharmacology without boring old flashcards? Check out the Nursing Pharmacology crossword puzzle book from MedEd 101. It's an Amazon bestseller. It turns drug classes, mechanisms, side effects, and high-yield facts into fun, brain-boosting puzzles that help you remember what matters most. With over 2,000 questions and clues, it's perfect for study breaks, group review, or solo practice. This book makes learning pharmacology engaging. Grab your copy and start mastering meds in a way that's actually fun. Find it now at meded101.com/nurse. That's meded101.com/nurse. All right, some drug interaction mechanisms. So I alluded to a couple, or I alluded to CYP2D6 being a specific enzyme. That's one I'll mention here as well. CYP3A4 is probably the most common enzyme that breaks medications down, and that's the one where you're going to see the highest number of drug interactions. So CYP3A4, that's a good one to remember. Now, typically, most medications are active, and so if it's broken down by CYP3A4 and we block this enzyme with another medication, that could cause the concentrations of the other drug to go up. All right, so now here's where it gets a little tricky. So let's take the example of codeine. So codeine is actually converted to more active morphine. This is an opioid pain medication. So codeine actually gets converted in the body to morphine by CYP2D6. If we inhibit or block the action of CYP2D6, we could actually have less opioid effects because codeine is a prodrug. So that's kind of a challenge, a little more challenging concept to understand there. But if we've got a prodrug and we inhibit an enzyme or block an enzyme, we could end up with reduced efficacy or reduced concentrations of that more active drug. Alteration of renal elimination. This is definitely a common source of drug interactions. Lithium and digoxin can definitely be subject to that, where some medications may affect that renal function, and lithium and digoxin concentrations could rise if those if the kidney function worsens there. Absorption alterations. This is a common drug interaction mechanism as well. I would say probably most commonly are some of the antibiotics. So like quinolone antibiotics, that would be like levofloxacin. Some of the tetracycline medications like doxycycline. If we give calcium or iron at the same time, both by mouth, what can happen is the iron, calcium, it can basically stick to those drugs and prevent them from being absorbed. Okay, so that's definitely a common and a good drug interaction mechanism to remember. All right, so absorption alterations, going into that a little bit further here. Gastric bypass and some changes that way could reduce the extent of absorption. Slow motility. So if somebody has gastroparesis, or we give them an anticholinergic medication like diphenhydramine, that'd be brand name Benadryl, that slows down the gut, there is the potential that we could have increased absorption with that slower gut. There are rare examples of medications that require a gut transporter, so basically a pathway for the medication to get to the bloodstream. And sometimes those transporters can become what's called saturated, where basically we've got too much drug and not enough transporter. So that drug can kind of get stuck in the gut and it doesn't get across, and it may limit absorption that way. Onset of action. This is basically how quickly the drug is going to start working. Incredibly important in, ICU sedation, for example, where we want to get that patient sedated quickly. So that onset of action is going to be very, very critical. Another great example is opioid overdose. We want that medication to work right now, right? Within seconds to minutes. So the delivery of that medication is important. IV is going to be typically considered the fastest delivery. Not always the easiest, obviously, because you've got to, use a needle and, get to a vein and those type of things. And it's, obviously not accessible in a patient's home. That's not going to happen unless a healthcare team, arrives with an ambulance, those type of things. So that's the fastest, best way to get a medication to somebody quickly. But again, not always practical in outpatient and, not in a healthcare system. We don't have that option very often. So oral tends to be kind of middle of the road. If you take an oral pain medication kind of as needed, typically it's going to take 15, 30 minutes, maybe up to an hour, to kind of really begin to start working and kick in. Versus if we gave an IV opioid medication, that would be in the bloodstream right away and it would be working quickly. Versus orally, it takes some time to absorb. Transdermal, typically this takes a while for drugs to get through the skin membranes, basically. That's generally a pretty slow process. So that generally has a slower onset of action. Again, can vary based upon, the intrinsic property of the drug and the delivery system. Lipophilic medications. So these are basically more fat-loving medications. Think of kind of the oil and water example. Lipophilic medications would be attracted or go into the oil layer a lot better than it would go into the water layer. Lipophilic type medications cross the blood-brain barrier much better. All right, digging into these a little bit further here, I discussed them like intravenous a little bit on the last slide. Inhalation is generally pretty rapid. It goes when we inhale something, like an inhaler, that type of thing. We generally got a pretty large surface area and rich blood supply in the lungs, so that absorption is generally pretty quick. Sublingual, buccal, pretty rapid onset there. We do get to bypass first metabolism in the gut there, so that's a nice thing. But not all drugs are, readily available to be used that way either. Intramuscular, so this is pretty close to IV. It's a moderately quick onset, I would call it. Absorption may depend a little bit upon, that muscle perfusion and how quickly the blood's getting there. Sub-Q, so this is kind of into that, fat layer right below the skin. It's slower than IM, but faster than oral in many cases. Oral, again, slower onset, can definitely be affected by some of the, gut issues and considerations, as well as that first pass metabolism. Rectal, variable onset. This does partially bypass at least that first pass metabolism. These are much less commonly used. Transdermal patches, very slow onset, slow absorption generally. Topical, generally we're going to use topical agents for just the local effects. So we're generally not looking for systemic absorption and changes in those type of things. So hopefully they work in a relatively reasonably fast manner. Intranasal, relatively fast because those drugs can be absorbed through the mucosa. Intrathecal, epidural, fast, targeted, right within the CNS there. So those are pretty quick. And then we've got implantable devices, which generally this is more so a slow or prolonged release. Because obviously if we're implanting a device in somebody, we want that to release drugs slowly. We're not going to, be in and out taking this implantable device in and out, or putting it in every week, for example, if we don't have to. So that drug release is generally going to be slow from something like that. All right, bioavailability. So this concept is basically how much of that drug is absorbed into systemic circulation, into the bloodstream. There are a few factors that impact this. So the drug itself, that's probably common sense there. The delivery route, so, IV is going to be 100%. So, a good example is a medication like levofloxacin. We've got IV available, we've got oral available. IV, it's 100% bioavailability. So you're getting all that drug, all the dose that we want there. With levofloxacin, it actually has very good oral bioavailability. This medication is absorbed significantly. So when we dose convert people, we can generally go 1-to-1. 500 milligrams of IV levofloxacin is equivalent to, pretty close to 500 milligrams of oral levofloxacin. Now, a great example of a medication that doesn't have good oral bioavailability is vancomycin. So naturally, it's 100% bioavailability when we give it IV, but when we give it orally, that is absolutely not the case. So you cannot use oral vancomycin for a systemic infection or for pneumonia or anything like that. The only thing I've ever seen oral vancomycin used for is gut infections. So great example there would be like C. diff, where that infection is right in the gut there. And then we've got first pass metabolism. An example of a medication that has high first pass metabolism is budesonide. That's a corticosteroid. We've also got drug-food interactions can impact bioavailability, physiology, GI tract. So if somebody's had, GI tract surgery, maybe they've had a bypass type surgery, that may limit absorption and ultimately limit bioavailability. All right, as far as nursing responsibilities and what you should think about with regards to pharmacokinetics, monitor for therapeutic efficacy. If you see that a drug is working or not working, or, toxic or not toxic potentially, that could be indicative of a pharmacokinetic change or a pharmacokinetic problem. Okay, so recognizing and evaluating those patient responses. We can also, depending upon the drug, we may also have drug levels. So that's something that you can, look at, think about, is that something we can do to make sure the patient is absorbing that medication and getting it in the bloodstream if that's where it needs to be. Educate patients on expected outcomes, what's going to happen there. Of course, educate about side effects and toxicity, and then recognize that changes in drug therapy, not only can they cause side effects themselves, but they can lead to drug interactions. So really, really important to recognize that, and especially in our geriatric and polypharmacy folks, for sure. And then help us from a healthcare team. If you know a patient has had worsening liver function, worsening renal function, those two organs are so important in breaking down medications and drug concentrations. So if you know that the patient has had changes in either of those, that could cause to an alteration in drug concentrations. Struggling with nursing pharmacology? Would you like a resource you can put in your hands? You're not alone. If you want to understand medications instead of just memorizing them, check out the MedEd 101 Guide to Nursing Pharmacology on Amazon. Written by a board-certified clinical pharmacist, this book breaks down high-yield drug concepts, clinical pearls, and real-world examples that actually stick. Perfect for exams and the bedside. Whether you're in nursing school or already practicing, this guide helps you build confidence with medications fast. You can find a direct link to the 233-page book right now at meded101.com/nurse. That's meded101.com/nurse.